This video is a little introduction and conversation about intravitreal injections. Intravitreal injections used to be performed once in a while before 2005. They used to be applied, for example, for injection of gas by retina surgeons, injection of antiviral or antibiotic medicines for infections in the eye. But then with the introduction of anti-VEGF agents, 2005 or later, there was an exponential increase in the number of intravitreal injections performed. And nowadays, just in the United States, over 5 million intravitreal injections are performed every year. With that in mind, you may keep in mind that complications are rare, but they must be avoided or reduced because the procedure is so frequent that the total number of complications may be significant. Fine details or improvements in the approach and technique and protocols of intravitreal injections may improve outcomes. So the first thing you want to do is to have a nice protocol preparation of the patient. You want to apply anesthesia drops at least twice, and you want to make sure that you apply povidone iodine a few minutes before procedure, because it takes 3 to 5 minutes to reduce the flora on the surface after application of povidone iodine. You may repeat iodine a few seconds before injection to make sure the new bacteria that was introduced by the blinking, the recent blinking, is removed, but it's very important to reduce the flora as much as you can. There are a few drops available: lidocaine, tetracaine, proparacaine, and you may use one, the two, or all of them. Gel have been introduced to improve anesthesia and reduce discomfort, and some specialists do use lidocaine gel in the preparation. But there has been some discussion if the gel blocks the penetration of povidone iodine. For the introduction of the needle, the injection itself, it's very important to put the needle in the right place in the intravitreal cavity. I noticed that many specialists, ophthalmologists, ask the patient to look to the side, so they make room for the needle. However, this is not a very beneficial approach. If you ask the patient to look to the side to inject, for example, here temporal, depending on the angle, you may penetrate the needle near or touching the lens. So more or less, you may ask the patient to stay in PPO or look a little bit to the side. And then you want to inject the needle right in the center of the vitreous, far from the retina, not to induce any tear, far from the lens. Usually 6 to 8 millimeters penetration is a good one. So the needles are either 8 or 12 or 13 millimeters in length. So you want to inject 2/3 of the needle inside the intravitreal cavity. After the injection, you want to wash the eye so the patient doesn't develop keratopathy by the povidone iodine. However, it's very important to wash with a sterile solution, not with a BSS that's sitting there in the clinics for several weeks. It's important to discharge the patient once the patient has good retinal artery perfusion and a good visual acuity. And to give instructions to the patient, that's very important, to contact your clinics and you if the patient has any abnormal pain after intravitreal injections or changing vision that can be a sign of endophthalmitis. I hope this initial introduction and tips may be useful to you. We're going to come to this topic in the future with more details.